to Core Connect Episode 3, a unique platform where the worlds of cardiology and endocrinology come together to share insights, bridge gaps, and strengthen our collective understanding of cardiometabolic health. The name Core Connect truly reflects the essence of today's program, where we are connecting the core disciplines that lie at the heart of patient care. Cardiologists and endocrinologists often encounter the same patient from two different perspectives, one focusing on the heart and other on hormones and metabolism. Yet it is only when we connect these perspectives we can truly achieve the essence of holistic, preventive, and personalized medical care. Over the next 2 hours, we will go through a series of thought-provoking discussions that highlight the intricate links between both the specialties. Our expert faculties will take us through the evolving evidence, novel clinical approaches, and collaborative strategies that can make a real difference in patient outcome. So without further ado, let's begin this exciting journey of collaboration and learning for next 2 hours. And it is my immense pleasure to welcome our both the course coordinators and moderators for today's program. We have Dr. Rajiv Agarwal from Meerut, who is a consultant cardiologist at Jaswant Rai Specialty Hospital, and Dr. Gagan Priya. She is an empaneled consultant endocrinology from Fortis Hospital, Mohali. It is my immense pleasure to welcome both of you. I'll just display the CV of Dr. Rajiv Agarwal, who is joining us today. And I'll quickly go through Dr. Gagan Priya's CV as well. And I once again have a warm welcome of Dr. Rajiv Agarwal. And sir, over to you for taking us the proceedings of the first session. Over to Dr. Rajiv Agarwal.
Thank you. And in fact, it is a unique opportunity for me to listen to so many giants in cardiology, and it will be personally a very gratifying evening to learn from all my colleagues who are doing exceptional good work in cardiology. And in that spirit, the first talk is by Dr. Praveen Chandra, who is well known to us. He is an intervention cardiologist working in Delhi for more than three and a half decades, good friend to me, always helping. And he's talking on a very important topic, DAPT after PCI. As you know, there is an immense progress in terms of antiplatelet therapy, stent biotechnology, and implantation techniques. Bleeding is a real nightmare for interventional cardiologists. At the same time, there is another issue which we have to balance is the atherothrombotic risk of coronary artery disease on top of it when we have stented coronary artery disease. We always want that DAPT should be as short as possible so that we have less of bleeding. And the topic is very catchy. How short is short? And I'm sure in next 15 minutes, Dr. Praveen Chandra will take us through the journey of dual antiplatelet therapy and what is the current pattern of practice, which is evidence-based, that how short is short. That means how early we can put the patient on SAPT and what is this SAPT. So I welcome you, Dr. Praveen Chandra, and kindly enlighten us on this very important, very contentious issue that how short is short.
Right. So thank you very much, Dr. Rajiv, for these words. And everybody knows how much is your experience. You are, heavily experienced in field of cardiology today. I think one of the most experienced people in at least Northern India or in the entire India. So today you have raised this point of dual antiplatelet therapy. And after PCI is something which is very important because after PCI, many times we were seeing complications happening like bleeding, like restenosis, like thrombosis, and all those things were really hurting us from the very beginning. But now we have been able to come to a point where we say that, we have reached a equilibrium, like, where we have been able to balance the bleeding complications, and also the thrombotic complications. So everybody today knows that for acute coronary syndrome, acute MI, and post-angioplasty patients, dual antiplatelet therapy is mandatory. But for how long and how much, that is what I'm going to discuss today, and what are the guidelines that we have right now. So all this story started when we started doing angioplasty, but then there was not such a problem in the era of below 2000. But when stents started coming in, then ticlopidine was the agent which was used for prevention of stent thrombosis. But still, stent thrombosis was very high. Now, clopidogrel came, and clopidogrel showed that it is much superior to ticlopidine, and everybody switched to clopidogrel plus aspirin therapy, and usually we were continuing that for at least a period of 1 year. And then, of course, more potent antiplatelet agents came in, which are known as P2Y12 inhibitors. This is known as ticagrelor and prasugrel. So ticagrelor was found to be superior, but again, the problem of bleeding start coming in with that. And also, prasugrel was even more potent, so the bleeding complication were slightly more higher. So that is why we were trying to kind of balance as to which drug to give, how much to give, and how long to give in these patients where we want to balance the ischemia and bleeding, because both are important for long-term risk for any recurrent CV events. And these patients who have ACS and stenting have to get two or one of the drug for a period of time. So today I'm going to discuss with you as to how short can come. Like, earlier everybody used to say that up to one we have.
Praveen, you are muted.
No, I got disconnected actually.
Yeah. Okay.
Sir, maybe you can switch off your camera and maybe go through the presentation. Bandwidth is low. Sir, should we wait or should we go to the next part maybe by the time he joins in, sir?
What you want to do?
Sir, 1 or 2 minutes we'll wait, and then maybe Dr. Charan is already in. Then maybe we can go for second session, and by the time if yeah, Dr. Praveen is here. Sir, can you hear us, Dr. Praveen?
Yes, I can hear you. I am now connected back again.
Yes.
I'm so sorry. This is because I'm traveling right now. So so can I resume my presentation?
Yes, sir.
Yes.
Maybe by the time maybe you can switch off the camera. If bandwidth is low, then maybe
Okay,
it will
okay.
help you. It will help you, sir.
Okay, that's helpful. So can you see my slide?
No.
Not yet, sir.
Not yet. Okay. So how do okay, I have to share it again. So I'm sharing it again. Share. Is it okay now?
No.
Yeah.
Yes, it is fine now.
is now available. So I'm just switching off my camera. That will be better.
Yes, yes.
Yeah, that's fine now.
Good.
That's better. Okay. So with this, I am
Sir,
now.
can you please go full screen, sir?
Yeah, I'm doing that. Yeah. Is it full screen now? Yeah.
No,
Yeah.
no,
Okay.
no. Yes.
Yes, yes. Okay. It is taking some time. Okay. So as I was talking to you, I'm so sorry. So with risk of stent thrombosis and ischemia are interrelated, and we have to identify those patients who have high risk factors for ischemia and those who have high risk factors for bleeding. So, history of prior bleeding, female low weight patients, anemia patients, and those patients who are on steroids for various reasons, or NSAIDs, and patients who are diabetics or chronic kidney disease and advanced age. So, these are the patients who have higher chance of bleeding. So, those are the patients where we have to really look at this fact that how we can optimize therapy for less bleeding and more prevention of ischemia. So
I'm
here
sorry,
there
can
are
you say
these
that again, please?
here there are so many studies which have
I'm
been done.
sorry, but I
So
can't
stop
help you
for
with it right now.
hello. Can you hear me? Yeah. Hello.
Yeah,
Can you hear?
we can hear you, sir.
Great, great. So basically these are the studies. This is and here you can see that there are so many studies which have been done, including Zine Short DAPT program, 1 month DAPT, Stop DAPT, too many global leaders, and all have studied what? 1 month versus 6 months, 1 month versus 12 months, 3 months. Then what happens? That you give dual antiplatelet for 1 month or 3 months and then follow it with either aspirin, or you give the P2 wildfire inhibitor like either ticagrelor or clopidogrel as monotherapy. So either of this can be done, and most of these studies really showed what? That there was similar benefits at standard DAPT with less bleeding risk. So which means we can easily do this shortening of therapy like 1 or 3 months in those patients definitely who have high bleeding risk, which I told you who are those high bleeding risk patients we have to identify. And based on these studies, this is the recommendation which is available now. You can divide your patients in two groups. One is stable CAD or acute coronary syndrome, and whether they have high bleeding risk or normal bleeding risk. So it makes life simple. And here you can see that in many situations where the high bleeding risk is there, you can do dual antiplatelet only for 1 month, followed by just 3 months of full, monotherapy, or as ESC or in ACCHA. These are the bifurcation. So most of them, these guidelines, both of these guidelines are almost similar. And here you can see for this normal bleeding risk patients, you can give up to 1 year also if the bleeding risk is low. So that is the current recommendation, and we can use that. And definitely, this is the way we decide. This is the 2023 ESCA CS guidelines, again showing that it is a class 1 recommendation to give dual antiplatelet for 12 months. But ticagrelor is recommended irrespective of treatment strategy, whether invasive or conservative, which is a class 1 indication. And in high bleeding risk patients, we can give initial monotherapy and followed by single dual antiplatelet for 1 month, followed by single antiplatelet therapy, which is a class 2B recommendation. So based on these recommendations, we can make our plans, we can adjust the dosages, and also depending upon the high bleeding risk versus high ischemia. Like for example, if a patient is having small vessels, having multiple stents, long stents, in these patients we need longer duration of therapy compared to those patients where the ischemia risk is not too much. And also we balance the bleeding risk in those patients and make our decisions. So that is the very short summary of what exactly is the situation. So these are the recent evidences where it is also shown that if you give ticagrelor plus aspirin versus ticagrelor plus placebo, as you see here, the ischemia is same. So there is no increase in ischemia with monotherapy. But if you give both, the bleeding risk is higher. So which means you can reduce bleeding risk in these high risk patients by just giving monotherapy with ticagrelor. ticagrelor in these patients. So in high risk patients after CABG also, similar thing can be done to reduce the risk of bleeding and just give monotherapy of P2Y12 inhibitor like ticagrelor in these patients. To evaluate ICS, so many studies are now available which are just suggesting the same thing, that you can give monotherapy and in these patients without increasing the risk of ischemia. So these patients with ACS, with drug-eluting stents, all we can treat with monotherapy for duration of up to 1 to 3 months, and then followed by just aspirin or ticagrelor in these patients. So that is the master DAPT study. Again, DAPT after PCI in patients at HBR shows that abbreviated DAPT is also good in terms of reducing bleeding complications. So similar TPAS study, stopping aspirin within 1 month after stenting for ticagrelor monotherapy. So this is, the data is very now kind of almost reached to a point where we can say that we can safely continue dual antiplatelet for 1 month, and now even we do it for 1 week when we do not even put stents. We do drug-eluting balloons. 1 week or 2 weeks patients can go under surgery also, and very safely. So that is the current situation, and this is the bleeding risk reduction which has been seen, as you can see in the ultimate DAPT study, ticagrelor or alone versus ticagrelor plus aspirin from 1 month to 12 months after PCI, and you can see that complications are much lesser in ticagrelor plus placebo compared to ticagrelor plus aspirin. And of course, the MACE endpoints were similar. So it is very safe to do this today with all this data from ultimate, the previous studies, the DAPT2 and this is the meta-analysis which is now available, which shows that, you can do ultra short, less than 1 month DAPT also. And basically, these patients can be, in terms of mortality or cardiac, any risks are much, much lesser. So the takeaway based on these recent evidences is that short 1 to 3 month DAPT followed by P2Y12 monotherapy or aspirin also is good enough for all comers undergoing PCI regardless of clinical presentation. So this is quite easy. And longer term therapy, DAPT with more potent consistent ticagrelor or clopidogrel is best for low risk patients. So that is the current situation, and we can continue this therapy up to 1 year for lowest risk patients. But definitely in the these guidelines which are now available, as you see here in the 2025 guidelines, now it is absolutely okay to continue this for short duration, and they have upgraded this to 2A or 1 also. So that is this is the final chart showing that we can give DAPT for all patients, but high bleeding risk patients we can reduce it to 1 month or 3 months therapy. So that is the the very compelling now data which says that it is very safe to do this. So I'll stop here. Thank you very much. If you have any quick questions, I can answer that. Yeah. So Dr. Rajiv, I think if you have any quick comment or question, please go ahead, and otherwise we can move on.
Sir, you're mute, Dr. Rajiv.
Dr. Rajiv is mute.
What I learned from this lecture is there is no short DAPT less than 1 month. So you can't have aspirin-free PCI today as the evidence said, what had been emphasized. So 1 month of DAPT in high bleeding risk patient is mandatory. And there is some literature which talks like New Mindset, which talks about 4 days of aspirin, but you see the events were more in SAPT group in less than 1 month. So Dr. Praveen Chandra had been very, very emphatic that 1 month DAPT is mandatory, and anything around 3 months in high bleeding risk, also guideline oriented, and 12 months is default in a routine patient. I think they are the two simple things I could carry home. Thank you, Dr. Praveen.
Thank you.
And if you have not to go somewhere, then you continue to be with us because the
Yes.
people want us that all the questions will be in the latter part of the symposium.
I'll join.
So
Yeah.
I invite another colleague of mine, Dr. Professor Charan Lanjewar, who is a senior intervention cardiologist, professor and unit head at KEM Hospital, Mumbai. And he is talking on yet another very, very important topic. Are we missing the pulse of young hypertensive patient, management of hypertension with high pulse rate in young patients? I think this is another very contentious issue. Till recently, all the guidelines were putting beta blockers in the backdrop or the backyard, that they can't be used as first line therapies. Indian doctors, Indian guidelines continue to use beta blocker in appropriate young patients. And to our surprise, ESE came back with somersault that now beta blocker in an appropriate patient can be used as an antihypertensive therapy. We have large number of patients who are hyperadrenergic, hypertensive, and they need beta blockers. So I invite Dr. Charan to throw some light, dissect out with clarity that who are the patients in hypertension who needs beta blocker, although now we are getting more and more evidence in favor of them. I welcome you, Dr. Charan.
Thank you very much, Dr. Rajiv Agrawal sir, and all the eminent cardiologists in the group and INTAS for giving an opportunity to talk on a very interesting topic, that is hypertension and high pulse rate of detriment. So, do you want me to share from my desktop?
Yes, sir. You have the slides with you? Yeah.
Yes, I do.
Yeah, please.
Give me a moment. Yeah. Okay. They are visible, right?
Yes, sir.
Yeah. So hypertension and high pulse rate, a detrimental combination in how to manage the scenario. So if you see recently the prevalence of young hypertensives in adults, particularly 20 to 24 of age, one of the study also mentions 1 in 8 patients would have the hypertension in those patients. What are the peculiarities of those? Most important is onset early in the life. They come with a clustering of multiple cardiovascular risk factors, like it could be diabetic or it could be some smoking. These are the things which would be there. And significant seasonal variation of the blood pressure is also been noted. There is a low awareness and treatment and control gates. And we have a high incidence of end organ damages in those group of patients. So considering this, so what are the common risk factors? As you know, the dyslipidemia, obesity, diabetes, hypertension, insulin resistance, they all come together and generally they cause a microvascular either or a macrovascular disease by different pathomechanism like atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and ultimately a cardiovascular problem. So hypertension is frequently coexists with the obesity, diabetes, hyperlipidemia, and their association has been well established through so many years. So management of these risk factors is an important part for the overall management of hypertension in the age group. If you see the risk factors, generally the sedentary lifestyle in younger people, obesity and mental stress remains the most important thing, apart from the non-modifiable risk factors. Coming to the sympathetic overdrive, which plays a major role in the pathophysiology of the cardiovascular disorder and hypertension. If there is a sympathetic overdrive which causes more heart rate and which essentially leads to the more left ventricular hypertrophy, vascular remodeling, and all these problems associated with the tachycardia and the vasoconstriction. So as such, the increased heart rate and the increased systolic blood pressure in combination, both of them are known in objective parameters as in deciding sympathetic overactivity in younger adults with the hypertension patients. So whenever there is an elevated heart rate,
Good evening.
if the patient is hypertensive, it increases the risk of CVD. And if it is if it is a normal human being without any hypertension, can have the risk of hypertension in the future. So pre-hypertensive patient with a heart rate of more than 80 found to have 50% increase in overall mortality as far as the current hypertensive, which the study which was published in the research. The elevated heart rate plays a central role in the ischemic heart disease also by increasing the myocardial oxygen demand and the consumption, which ultimately leads to more, with the increase in the resting heart rate, causing twice as likely to develop the ischemia in those patients. So if you have an elevated heart rate, either you can associate an increased systemic inflammation and endothelial dysfunction, which is considered to be a predictor of a poor prognosis, and it is significantly associated with HEPPEF as well as the HEPREF patient. So also with the heart failure patient, it has a deleterious effects. Coming to the prevalence, if you see the prevalence, one of the study we showed overactivity sympathetic was diagnosed in almost in 62% of the patient of the adult patients. So sympathetic overdrive is associated with the development of multiple cardiovascular risk factor, which I already talked. It is more commonly associated with the increase in the mortality, particularly in the middle-aged men with hypertension and or diabetes. The adverse cardiovascular outcomes which are associated with this are mainly due to release of the norepinephrine and stimulation of the beta-1 receptor in the heart and the kidneys. So if you see the elevated heart rate, how does it cause the relative risk of death versus the HR? If it is heart rate less than 60, the mortality is very less. When you go to the heart rate more than 100, you can see that 3.1% mortality can be noted. In this diagram, you could see the 50% difference in the incidence of end organ damage in those group of patients. How is the difference between the male and female? There is twofold increased risk of cardiovascular mortality if you have a tachycardia and hypertension versus threefold rise in the CVD mortality and risk if the female is having the tachycardia and hypertension. So that's how females are more common as compared to males as far as increased risk with the CVD mortality association. Coming to the after sympathetic overactivity, most important also is the plasma renin activity. In a younger hypertensive patient, the plasma renin activity is noted to be high. If 20 to 30 and 30 to 40, you could see that 0.5 to up to 2 nanogram per ml per hour is a plasma renin activity, which goes down with the each decade onward. So higher plasma renin levels are strongly and independently represent to high CVD risk, SCD, and death due to heart failure in those patients. When compared with the participants in the lowest PRC quartile, those in the highest quartile obviously were having an increased risk of cardiovascular mortality. Pathophysiology is same as cascade shows, sympathetic, which I talked about, the cardiac function, the endothelial dysfunction, and how the renal deleterious effects occurs. If you are blocking those action at that moment, utility would be better with the beta blockers. Another is the activation of the RAS system. So RAS inhibitors will play a major role in the treatment of those group of patients. So that is the thinking behind this main presentation here. So primary distribution of beta-1 receptors generally you can see is in the myocardium and the kidney. However, the beta-2 receptors are mainly placed in the bronchi and the peripheral vessels, smooth muscles, vessels. So in the myocardium, they are responsible for increased contractility and heart rate and increase in the myocardial necrosis and apoptosis, while in kidney, increase in the renin release, while beta-2 receptors causes bronchodilation and vasodilation. So whenever using a high selective beta-1 blockers like metoprolol, bisoprolol, they would inhibit the sympathetic activity in the heart and kidney and also preserving the beta-2 receptor actions such that there is there is no hampering of the bronchi or the vasodilation. So this is the RAS involved in the development and prognosis of the hypertension complications, and where the RAS inhibitors plays a major role in reducing the left ventricular hypertrophy, fibrosis, and cardiac remodeling. Also at the kidney level, GFR, proteinuria, and aldosterone release. When you talk about the BP targets, so considering this high rise of blood pressure in younger population, particularly in Indian patients at the third decade, we could screen the patient at the age of 35 years. And as for a modern personalized approach should be there, for standard, you could, as a therapeutic treatment, if there is a blood pressure more than 140 by 90, you can think about therapeutic intervention, while the lifestyle, along with the lifestyle modification, that is enhancing less than 130 by 90 blood pressure, and individual approach depending on any comorbidities, you could decide as far as targets are concerned. Of course, lifestyle remains the most important therapy in all of those patients. You have to rule out the secondary hypertension. Obviously, this talk is about the primary and essential hypertension. So, but you need to rule out, as the younger population, you need to have to rule out the secondary hypertension in those group of patients, in particularly if there is any suggestion, clinical suggestion or investigation suggestion on the examination. So Indian guidelines, as per hypertension 2019 guidelines, there are 5 classes of drugs which can be prescribed. This include ACE inhibitor, AT2 receptor blockers, calcium channel blocker, diuretics, and neo-beta blockers. So younger individuals have high renin activity. So this patient, these are preferred on ACE inhibitor or ARB with beta blocker combinations. Also, they can be put on a CCP as the second line of therapy. So depending on number of guidelines at ACC and ESC, they are mainly agreed on the starting with the 2-drug combination if it's a stage 2 hypertension. If it is a stage 1 hypertension, you could start with 1 drug, try to control maybe about 1 to 3 months, and then you can add another. If you're starting 2-drug combination, the single pill combination is recommended to improve the BP control and adherence. Beta blockers are recommended as first line in the patient who has the coronary artery disease or a heart failure or having a tachycardia. These are preferred also in the heart failure patients. So these are the ESC chart 2024. So start with the low dose double combination therapy, either AC or ARBs or CCB or diuretics. If not, BP is not getting controlled within 1 to 3 months, you can reassess the patient, get it on the triple therapy. Again, you wait for 1 to 3 months, see how the response with the close follow-up, whether patient is taking the tablets or not. That is, adherence is most important in those group of patients. If the patient is not adhered, we generally mistakenly label him as a resistant hypertension. So that care should be taken by the physician and the consultant. So see whether it is not a false resistant hypertension. And at any state, add a beta blockers if compelling indications like angina, post-MI infarction, systolic heart failure, or heart rate control, as far as the compelling indication is concerned. If maximally tolerated triple combination therapy, again you wait 1 to 3 months. If apparent resistant hypertension, despite ruling out the adherence problem, then you could add the spironolactone or other agents from the other group, like central acting group, or the diuretic therapy can be added at this juncture of time. Or the recent drugs, which are the ARNI or SGLT2 inhibitor, also sometimes can be useful in those group of patients. So particularly beta blocker, atenolol, metoprolol, they have significantly reduced the incidence of stroke, heart failure. In number of trials, it has been shown in the RCTs and also in the meta-analysis. So heart rate more than 80 is not acceptable in those group of patients. So try to get your heart rate less than 80 in those group of patients to have the effect as far as morbidity and mortality is concerned in both arms. So this is the diagram where is shown the dark blue color. This combination can be combined very well in number of indications in the hypertensive patient. Again, the same thing has been shown here. Uh, the step 1, step 2, and step 3. This has been published in the Journal of Hypertension, where the beta blocker can be combined in any group when there is an indication arises in those group of patients. So I think there's a survey which was done by the company, and the survey which shows amongst the ARBs, the telmisartan was the main choice, which was preferred by about more than 80% clinicians and the cardiologists in managing the hypertension in young adults. When there was a sympathetic overactivity, the beta blocker were combined, and this was about in a patient of 40 to 60% patient. This combination was favored, comparing metoprolol and the telmisartan. Coming to obesity and hypertension, again, in the patient who has the obesity, these are the patient who has, basically these are the metabolic syndrome patient. Yes, this requires the AT2 receptor blocker, AC or AC inhibitor, and the cardioselective beta blocker associated with the sympathetic overactivity. So these are also the group of patients where this group of patient would require a beta blocker and this combination. So coming to emerging controversies, there's a lifetime CV risk paradox. This is very commonly noted with the young hypertensive patients, because in the younger generation at the 3rd decade and 4th decade, there is a low risk. They come into the very, very low risk. But if those you follow those patients, these are the patients who will have the other vascular problems in the future, maybe at the 6th or 7th decade. So early control prevents the irreversible vascular aging that manifests decade later in those group of patients. So that is what the lifetime severe risk paradox is known as. Another is organ damage detection. You need to be very careful in detecting those, because most of this patient maybe is asymptomatic. So you need to, by doing investigation, rule out the organ damage, maybe echo to know the LVH, or retinal testing by the ophthalmologist, and the intima thickness has to be done by a carotid Doppler. Therapeutic inertia remains important aspect in a treatment of hypertension in cardiology, because we've seen that 30 to 40% of the cases are labeled who are labeled as resistant hypertension are mainly due to poor adherence and inertia of therapy start. So in take-up message, increase in sympathetic activity and increased renin release are the core pathophysiologic mechanism for hypertension in young. Sympathetic overdrive is associated with the development of multiple cardiovascular risk factors, the main cause of hypertension in young and middle-aged men. Younger individuals have higher renin hypertension. Resting elevated heart rate is associated with the increased morbidity risk and mortality risk. Latest hypertension guidelines, including the Indian guidelines, recommend single pill combination comprising 2 drugs for controlling in most patients, and it also recommends beta blockers as one of the first line therapy for the patient who had elevated heart rate more than 80 beats per minute. As sympathetic overactivity is becoming more common in younger adults with hypertensive patients, cardioselective beta blocker is the ideal treatment option. So thank you very much, sir. Thank you all audience and the interns once again.
Thank you, Dr. Charan, for very enlightening talk. And very interesting to note that there is a crosstalk between sympathetic and renin-angiotensin system. And there is a subgroup of patients where high adrenergic activity can be demonstrated clinically related to heart rate. And this is the subgroup of patients, especially young subgroup, where beta blocker can be of immense use. And as you have correctly said that beta blockers are coming back. Fortunately, Indian doctors never left beta blocker despite no evidence. We continued to use them and we have our own justification. So it is satisfying to note that the world is also coming back to the same concept. High adrenergic activity, young patient, you have a space for beta blocker at any stage with any drug. Thank you very much.
Thank you, sir.
We are coming to the third very important topic, which will be delivered by my dear friend, Dr. Anil Saxena. I consider him one of the most gentleman cardiologists in Northern India or India. He is known for his skills in electrophysiology. He is well versed with clinical cardiology as well as the uh, electrophysiology and ablations. Today, he is going to talk about something which is again very important, contentious, and we have some understanding about ARNIs in HFpEF. Who needs it? ARNIs had been with us for now more than a decade. We had been using them left and right in HFrEF. HFpEF is a new entity which we are learning every day. It's a diverse group. And these patients, they are older age group, obesity, diabetes, they are cluster of metabolic risk factors. And which is the subset of patient which can be benefited by ARNIs. We know Paragon HF is just missed the p-value, but still there is some hope that some group of patients in HFpEF can be benefited by ARNIs. I always consider the biggest challenge in HFpEF is the diagnosis, which busy clinicians find it difficult to make. So I invite my dear friend Dr. Anil Saxena to empower us with HFpEF and role of ARNI in a select group of patients. I welcome you, Dr. Anil.
Yeah, thank you. Thank you, Dr. Rajiv. It's indeed a pleasure and honor to share the platform with you. And I'm very happy to be here in this seminar to discuss about the HFpEF, which is something which I have a very special interest in. So let us see what evidence we have at the moment in these patients. As we know, all of us know that heart failure is a global problem, and we are having increasing problem with the patients who have heart failure with preserved ejection fraction. And as Dr. Aji pointed out, it's a relatively newly kind of identified entity. It has been there for a long time, but most of us were not able to recognize these patients, and the patients would keep going from cardiologist to pulmonologist with vague symptoms. But now increasingly we are recognizing these patients and labeling these patients as heart failure with preserved ejection fraction. But unfortunately, while we have a lot of therapies available for HFrEF, the HFpEF has been a difficult entity to treat. So today we will see how we can, to some extent, modify the clinical outcomes of these patients. Now, I will not discuss the global burden of heart failure much. We all know that heart failure across the globe, about 1% population may be having heart failure. And the same has been found to be true in India in quite a few registries. So we have a burden of about 8 to 10 million people of our country suffering from heart failure. Now, the important point is that the heart failure with preserved ejection fraction, now we realize, is almost as common as heart failure with reduced ejection fraction. And these are the definitions. So the HFrEF is called when the ejection fraction is 40% or less. Heart failure with mid-range ejection fraction or mildly reduced ejection fraction is like LVEF of 41 to 49%. And preserved ejection fraction is when we have a heart failure with the LVEF being 50% or more. And of course, there should be some evidence of increased filling pressure, either spontaneously or on provocation. So, and a very common test that we are doing nowadays is to identify elevated NT-proBNP levels, that is natriuretic peptide levels. And of course, on echocardiography, we can see that patient has diastolic dysfunction. These patients can be labeled, and of course, symptomatic patients, they can be labeled as those having heart failure with preserved ejection fraction. As far as the prevalence is concerned, about 1% of patients have heart failure, and they are almost similar distribution of heart failure with preserved ejection fraction as compared to reduced ejection fraction. And of course, they are also associated with similarly poor prognosis. So the 5-year mortality can be as high as 75%, but generally maybe around 30 to 50% in most registries. So it's a very, very important entity, yet we don't have a very good treatment for it. Basically, the goals of therapy in any heart failure, whether it is preserved ejection fraction or reduced ejection fraction, is that we want the patient to survive more. So increased survival is a very important outcome that we want for our patients. We want to reduce hospital admissions, and we want to make patients feel better. That is to go about their day-to-day activity in a better manner. So quality of life, survival, and hospitalization. These are the important outcome variables that we must try to improve in our patients. So let us see, today's talk is focused on ARNI. So let us see what is the clinical evidence of cardiac and renal benefits of ARNI in heart failure with preserved ejection fraction. So as Dr. Rajiv pointed, gave some reference to the Paragon HF trial, which was a very important trial conducted in patients with HFpEF, where they compared about 5,000 patients between ARNI and valsartan. And what they found was that there was some reduction in the hospitalizations for heart failure and death from cardiovascular causes. That was the primary endpoint. And the relative risk reduction was about 13%, but it, as Dr. Rajiv pointed out, it narrowly missed the significance. They also looked at other things, and basically because there was not much difference in the hospitalizations. That is what probably tilted the balance. But there are two important points I want to mention about this trial, Dr. Rajiv. One is that they tried to compare ARNI with valsartan, which in my view was not the right thing to do, because whenever we want to test efficacy of a new drug, we either compare it with placebo or we compare with the standard of care. Valsartan was not the standard of care, and they chose to compare ARNI with valsartan. Valsartan was neither here nor there, maybe partially effective. They have compared with the placebo, things would have been completely different. Like, for example, SGLT2 inhibitor trials have all been done against placebo, but this was done against an active comparator, which was not the standard of care anyway. So that was the first problem. Second issue about this trial being negative or positive is that we are like overemphasizing on this threshold of p-value, where we always want p-value to be 0.05 or less. And at 0.49, we will say trial was positive, and at 0.51, we will say it was negative. Now, this has been even the statisticians, they say that this is a very artificial threshold and should not be seen in isolation. We should not put overemphasis on this threshold, because we must look at the overall context of what we are trying to study. Now, in heart failure with preserved ejection fraction, we don't have a good therapy available to us. If it was a new statin, we should reject, say, 0.51 or 0.6 p-value. But when we are dealing with an entity where we don't have good therapies available, I think we should put some emphasis on this aspect also, that we must give some credence to this fact that we don't have good therapies available, and a narrowly missed p-value is not something that we should completely reject the trial as being negative. Now, even then, what they found was that if you take the two groups, if there was a pre-specified analysis of Paragon HF trial where they divided the patients into those having ejection fraction less than 57%, which was the median, and more than 57%. And they found that in the patients who had an ejection fraction less than 57%, ARNI was definitely more effective, so much so that it led to a significant benefit. So there was a 22% reduction in the primary endpoint. And in patients who had an EF of more than 57%, it was not effective. So there we can have some signal as to which patients are likely to benefit. So patients who have EF of less than 57%, they do benefit from ARNI as compared to those who have a higher ejection fraction. So that's a very important signal from this trial. And of course, they also found that it was more effective in women compared to men. Now, this slide shows the change, the renal parameters in patients with Paragon-HF trial. And what they found was that the change in eGFR over 192 weeks was less in patients who were given ARNI as compared to those who were given valsartan. And overall, the cumulative incidence of renal outcome was also higher in patients who were given valsartan as compared to those who were given ARNI. So ARNI had some renoprotective effect, and this slide again shows the same thing in patients who were diabetic versus non-diabetics, and we found that the ARNI was superior to valsartan in these patients as well. So the conclusion from the renal standpoint is that in patients with HFpEF, treatment with sacubitril valsartan attenuated the decline in eGFR, and clinically important renal events were less in patients who were given ARNI. Now, this is another trial. They persisted with comparing with the valsartan. So what they found in the Paramount trial again is that the effect of ARNI was found superior in terms of reduction in the NT-proBNP levels. So they found that after introduction of therapy, NT-proBNP levels fell significantly in patients who were given ARNI as compared to those who were given valsartan. So it had a significantly better effect at 12 weeks as compared to the valsartan. So based on all this evidence, the FDA expanded the role of sacubitril valsartan to embrace some patients with heart failure with preserved ejection fraction, especially those who had a lower ejection fraction. So what they said was that patients who have a lower ejection fraction, say less than 55% or 60%, they may be considered for RD therapy. And since LV ejection fraction is a variable measure, we must use clinical judgment in deciding whom to treat based on the symptoms and tolerance of other therapies that these patients require. So continuing with some more evidence, there is a trial called Paraglide-HF trial, which again looked at some endpoints. And this slide basically shows that there was again a greater reduction in the NT-proBNP levels in patients who were given ARNI as compared to those who were given valsartan as early as within first week. And they found that the effect was much more in patients subgroup who had LV ejection fraction less than 60% as compared to those who had ejection fraction of more than 60%. So this slide shows patients who had an ejection fraction of 40 to 60%, they had a much better effect with ARNI as compared to valsartan, as compared to those patients who had a EF of more than 60%. And this shows again the same thing in the table form, that patients who had ejection fraction of 40 to 60%, they benefited maximum with ARNI. This slide overall tells us about that the various outcome measures, whether it's time to cardiovascular death or recurrent events of heart failure or hospitalization, recurrent events of urgent heart failure, changes in NT-proBNP, all these clinical endpoints, they were better with ARNI as compared to the valsartan. And this slide highlights the safety aspect of the ARNI as compared to valsartan, where all the renal endpoints like the worsening renal function or renal mortality, all these endpoints were better with the ARNI as compared to valsartan. So to conclude, among patients with heart failure with more than 40% ejection fraction and stabilized worsening heart failure, ARNI led to a greater reduction in NT-proBNP level and clinical benefits compared to valsartan, and numerically fewer cardiovascular and renal events. And in a pre-specified subgroup with EF below normal, the effect of natriuretic peptide level and clinical outcomes were larger. So these data and evidence point to, again, a treatment benefit of ARNI in patients who have a relatively preserved ejection fraction that is more than 40%, but less than 60%. Now, this is another study which is basically a pooled analysis of Paraglide-HF and Paragon-HF trial. So about 1,000 patients from Paraglide and about 4,800 patients from Paragon-HF, total about 6,000 patients were studied in this particular pooled analysis. And both were quite similar to recent worsening heart failure events. So let us see the data from this pooled analysis. And as we can see, the primary cardiovascular endpoint was much better in sacubitril valsartan, much less compared to valsartan. In the patients in the paraglide HF trial, that is about 1100 patients. And if you pool both the groups, then again, the benefit was still significant. So the clinical and the primary cardiovascular endpoints were better with ARNI as compared to valsartan in the pooled analysis of the paraglide and Paragon HF trial with a p-value of less than 0.03. And again, the results, as we have been discussing, were better in patients who had a relatively lower ejection fraction, that is less than 60%, compared to those who had an EF of more than 60%. So this is an important signal from these trials. And the renal composite endpoints were lesser. That is a decline in eGFR and other renal endpoints were lesser in patients who received ARNI as compared to those who received valsartan. So that's an important point. Again, tabulated form, same data in table form that worsening renal function was much less in patients who received ARNI. So to take away from the renal endpoints, in the pooled analysis, ARNI resulted in approximately 40% lower risk of renal composite endpoints, supporting the nephroprotective effects of ARNI as compared to valsartan in heart failure patients. And in the pooled analysis of Paraglide HF and Paragon HF trial, ARNI reduced the cardiovascular renal events among patients with heart failure with mildly reduced or preserved ejection fraction. Now, this slide shows the metabolic effects of sacubitril valsartan combination, that is ARNI on serum lipids in heart failure. This data is from the Paragon HF trial, something which is very difficult to, I don't know the mechanistic explanation. In the trial, they have mentioned that there was some, basically related to the neuropeptide modification where the insulin secretion was better and other effects on the lipids and the liver. But what they found was that compared with the valsartan, sacubitril valsartan reduced triglycerides and increased the HDL. So that was a finding in the Paragon HF trial. But we still don't know what to make of this as far as the mechanistic or the clinically relevant endpoints are concerned. But that was an important signal from the Paragon HF trial that it has a favorable effect on the lipid profile. So we can expect some metabolic benefits also from ARNI in this regard. Now, coming to the guidelines. So there have been two important guidelines, 22 AHA-ACC Heart Failure Association guidelines, and second is the ESC guidelines of 2023. So they both have recommended that ARNI have as a class 2B indication that they may be considered in patients who have heart failure with preserved ejection fraction. Of course, diuretics, as we know, they are the class 1 agents. SGLT2 inhibitors have now become class 1 agents. In this particular guideline, it was 2A agent, but now we know that they are class 1 agents. ARNI still remains class 2B agent, though my personal opinion is that it should be assigned a better class for the reasons that I mentioned earlier. But the guidelines mention that the benefit is better in patients who have LV ejection fraction EF closer to 50%. So it is class 2B indication as of now. And there's another review which was published recently, which again mentions that in patients who have a LV ejection fraction of less than 55 to 60%, use of ARNI may be considered. So a lot depends on the patient's symptomatology also. Now, this is the guideline from the 2023 ACC Expert Consensus Decision Pathway. And they also have indicated the same thing that for women, that is all ejection fraction, and men with LV ejection fraction of less than 55 to 60%, we can add ARNI in this subgroup. Again, class 2 recommendation, not class 1 indication as of now. So this could be the management algorithm for heart failure with preserved ejection fraction. After confirming the diagnosis of heart failure, we again classify the patient whether the patient has reduced ejection fraction or mildly reduced or preserved ejection fraction. And all eligible patients, they should be given the lifestyle modification, including exercise and other dietary instructions. Then SGLT2 inhibitors are now a class 1 agents indication, as I said. So they should be given to all eligible patients. And subsequently, patients who have ejection fraction of 50 to 55 or 60%, the selected patient, they should be considered for ARNI therapy. Diuretics, again, as needed, they are a class 1 indication. And MRAs can also be given to selected patients. So this is in nutshell the therapy algorithm of heart failure with preserved ejection fraction. As far as the mechanism of action is concerned, I will not go into the details, but on the heart, they have a effect in remodeling. ARNI has a effect in LV remodeling and in reducing the hypertrophy and fibrosis. On the kidneys, they have a effect in reducing sodium reabsorption, so they lead to better natriuresis, and they also cause vasodilation of the afferent arterioles. And they also have important metabolic effects like lipolysis and lipid oxidation, and increased secretion of insulin and increased insulin sensitivity, etc. That might be responsible for the beneficial metabolic effect that have been observed. So, friends, to conclude, I would just say that in Paragon-HF trial, among the subset of patients with EF less than 55%, there was a 22% reduction in primary composite endpoint of hospitalization for heart failure and cardiovascular death, and that was statistically significant. In the Paraglide HF trial, there was a significant reduction in the NT-proBNP, and benefit was evident among patients with EF of less than 60%. In HFpEF practice guidelines to physicians released, they have given a class 2 recommendation for use of ARNI among heart failure with preserved ejection fraction, with the ejection fraction between 50 and 60%. And in this group of patients, we can consider ARNI, which can result in reduced cardiovascular endpoints and also have a protective effect and maybe some metabolic effects as well. So I think I will stop here. It's a very important topic, and we can have some questions. I'll be most happy to discuss. Thank you so much.
Thank you, Dr. Anil, for a very comprehensive review of HFpEF, not only in relation to ARNI, but overall how we manage these patients in overall scenario from SGLT2 inhibitors to ASARB, ARNI, and diuretics. So it's very, very comprehensive. And as you said, that probably there are some problems with Paragon. That's why it missed it, the choice of valsartan. It could have been against placebo. And when we combine Paraglide and Paragon, we are reasonably happy with the outcomes. So the challenge continues to remain the diagnosis, which still is very, very difficult in peripheries where I work. Maybe it is easier in your centers because you have a specialized echocardiographer who can guide you better. So with this, I have to change over to another topic, which is very, very important and I think very close to my heart: heart failure with recovered ejection fraction and long-term management strategies. Many of us feel like heart failure, if it is managed, treated, and the patient regains LV function, let us stop the drug. But we have everyday evidence against this approach that GDMT should not be stopped. And we have a wonderful speaker on this, Dr. Gaurav Kumar Chaudhary, who is interventional cardiologist and professor of Department of Cardiology in KGMU, Lucknow. Kindly once again guide us. That is there any subset of patient where GDMT can be stopped? All of us, we know it can't be stopped. Is there any subset of patient where it can be stopped? So I'm very keen to learn to you how we navigate in terms of medical therapy in patients who have recovered ejection fraction, or what we call HFpEF with heart failure with improved ejection fraction, or patient with reverse remodeling. So once again, I welcome Dr. Gaurav, and please navigate us through the maze of this problem. Thank you.
Good evening, and thank you, sir, for giving me this opportunity to be among yourself and to discuss a very important topic, as you have already said, that many times we are confused when to stop the therapy, whether to stop or not. So I would be just going through a brief overview. We all are aware that once we are treating a patient for heart failure, then major three goals are there. First, we need to increase the survival, because still, despite the best of the treatment, despite four pillars and availability of Versigua, still the mortality remains high. So there is always a residual risk, and there is always a scope for reducing the mortality. Still, it can be in the range of 20 to 50 percent at 5 to 7 years. And the main reduction in mortality is achieved by reducing the sudden cardiac death as well as death from the pump failure. And apart from increasing the survival, the next important thing is to achieve the reduction in the hospital admissions, because we know that once we patient develops heart failure admission, then he is more prone to go into a vicious downhill course, and that will further lead to a further decline of the ejection fraction, and the mortality becomes very high for the next visit if the patient again comes to the hospitalization. And of course, the quality of life is improved once we use the therapy, and it allows the people to live a better life, and a longevity is increased. So till now, we all of us are using these therapies like beta blockers, MRAs, ACE, ARBs, SGLT2 inhibitors, and of course, Versigua. Majority of us are using, although it has not shown a very strong data for mortality reduction, but but in worsening heart failure, it is acting. We all know that. So usually, what happens that initially we were referring to the various texts that show that there was a rule of one third. That means a patient, once you diagnose a DCMP, one third are going to improve, one third are going to remain stable, and one third are going to go the downhill course. And over the years, this was a historical cohort data, but now we have seen that up to two-thirds of the patient
ऑर्थो के ऑर्थो में
betterment of the there was some.
Yeah, sir, if you can switch off your camera and share the screen, that will help you with the bandwidth.
No, I think it's available. No? It's showing. The slides
Yes.
are visible. No?
Yeah, now, yeah, it's coming, sir.
Yeah. So over the years, we have seen once a patient develops a betterment of ejection fraction. Now, this is an objective definition that when a patient develops absolute improvement in 10% of ejection fraction, and many times we see the reduction in the end systolic volumes, and usually the EF becomes more than 40, and in super responders, it goes beyond 50 and 60. So there are various that and various medications that are shown to act. That what are the changes that are acting at the molecular level that are leading to a benefit in EF, which is leading to the improvement in EF. So we can see that majority of the drugs leads to shifting to a lesser apoptosis, lesser of hypertrophy, lesser of myocytolysis, and the this apoptosis is reduced, this fibrosis is reduced, angiogenesis is increased by a majority of the drugs, and LV dilatation is decreased. So it is acting not only at one place but numerous places, numerous known and unknown genetics and energetics comes into play. And we all know that there are various other factors apart from this routine risk factor that we know, that there can be tachycardia, there can be underlying thyroid disease. Once you use a CRT therapy, and if the patient is super responder, then that can prevent the remodeling. Or if you use the RAS blockade, and if in the case of peripartum, Then there are it's, I think, a complex of various factors that comes into play that leads to the different dynamics and different torsional mechanism of left ventricle, and they can have a different outcome when these risk factors are reduced. And we have been implanting CRT, and now we have with the use of ARNI and CRT. So we have a lot of super responders. So basically, this data came from, especially from the patient who underwent CRT. We could see, we all know that majority of the patient who are super responders usually have a non-ischemic etiology, lower duration of heart failure, female gender, no this LBB underlying, and there are various other markers that the patient who lack rate gadolinium enhancement, and the patient who have a lower NT-proBNP, lower TROPS, lower soluble ST2, and lower galectin-3 levels. So these are the patient in which we will see the favorable outcomes and the increase in ejection fraction. So there is a recovery. And we all know that plausibly it appears that heart failure recovered patient have a better biomarker profile and a more event-free survival as compared to the HFrEF and HFpEF. And still there are some disparity among some patients. It cannot be uniform that which patient is going to get better reverse remodeling, but there was some feature that I just told that these patients we expect to have a better improvement in ejection fraction. And there are various other reversible cardiomyopathy as well, like Takotsubo, this myocarditis, trastuzumab, chemotherapy induced ventricular dysfunction. So there are various molecular immune checkpoints where these thing leads to the decline in ejection fraction. And of course, there are some mutation as well. Now, invest the routine doing of this various mutation like lemon A oblique C, titin mutation. So they have seen that if they are present, then the patient is at more risk for this poor prognosis and more mortality. The presence of this fibrosis, again, late gadolinium enhancement is again a hurdle in recovering from this reduced ejection fraction. And we need to assess the strain as well, because many times the first thing to change, even before the EF, is change in this longitudinal strain. So GLS, this strain imaging should be done routinely once you start this ARNI, because many times before the improvement in EF, we observe this change in strain, as well as the LV and diastolic volumes and systolic volumes. So few years back, there was no specific trial addressing the issue. So there were small studies. We also did various for DM thesis, and we were having the signals that stopping this medication would not be that beneficial. So that there was a TREAD HF trial that was prospectively designed to address this issue and was published in Lancet in the late of 2018. That the patient in whom the therapy was withdrawal versus the patient in whom there was a continuation. So we could see the relapse of heart failure in withdrawal group was 44% as compared to the 0%, and is what is highly statistical significant, although there was no difference in mortality. So this was, although a small study, not very huge chunk of patients, it was just around 51 patient study, but we could see that we could conclude from that the withdrawal of heart failure medication may not be beneficial. It's even reverse that even if the patient develops a betterment of EF and you withdraw the drug, then this patient is very high risk again for the heart failure. So his EF may decline, and even before the decline, there would be some changes at the molecular level that we are not seeing, but there would be something that will help us to decide whether to reduce the therapy or just we should continue. So the most important thing, we should keep on checking the routine echo every initially 1 to 2 months, then 3 monthly, 6 monthly. Clinical examination, of course, is very important to see for any QRS widening in ECG or to see for any increase in NT-proBNP. And of course, this the CMR, of course, by seeing the late gadolinium enhancement change in the fibrotic pattern of that patient, or we should also assess very, I think, strain imaging here comes, gives a very good important role that even before the decline of EF or any increase in end-systolic volumes, we can assess by this global longitudinal strain. And of course, there would be some patient where you see if he is a case of Rajiv Gral sir was saying that there would be some subsets that we can discuss, and that there would be some subset where we can think about. Suppose the patient turns out to be hypothyroid and we give the therapy and he improves. And then there is a patient where we can plan to reduce the dose to the minimal and may even stop once there is total recovery. But these are not this prospectively, there randomized control trial. These are anecdotal reports where we can see that. And there are some newer things that routinely the people in US and European countries are following, that just doing this genetic mutation whenever the patient is diagnosed as DCMP, going routinely for this MRI and assessing the various lamin A mutation, this SCN5A mutation, this titin mutation. So you have a background that once you stop the therapy, then there would be, and if there's a presence of this malignant mutation, then we have to be more careful. And there are various data from the ICD studies which has shown once the therapy was reduced and once the ejection fraction improved, then the ventricular arrhythmia related appropriate shock also came down. They came down up to 14% as compared to the group in which there was no improvement in EF. So, of course, there was a reduction in the appropriate shock as well, but still up to 10 to 14% shocks were still seen. So, but overall, once a patient gets improvement in ejection fraction, then there is, of course, reduction in events for hospitalization for heart failure, as well as decrease in the events of ICD. So thank you, sir, for the this wonderful interaction.
Dr. Gaurav, and I think largely we need to continue GDMT in our patients who have recovered ejection fraction or reverse remodeling. And we hesitantly try to investigate some patient where volumes are normal, GLS is normal, and no increase in gadolinium scar. Maybe some BNPs are normal, and low ST2 and galectin. So it's a very comprehensive investigation to withdraw these drugs. But largely from clinical endpoint, I feel that we should continue the drug as before, because the neurohumoral modulation by these drugs resulted in improvement in ejection fraction, and in TREAD heart failure, 44% patients were going back to heart failure. So it's very important to continue. I'll ask my colleague, Dr. Ashfarul Haq, to say a couple of things because then we'll be winding off and passing the symposium to Dr. Gagan Priya. Dr. Ashraful, you want to say something, contribute on each lecture, the carry home points for the audience and what we learned today from these four very important aspects of clinical medicine. Dr. Ashraful.
Yes, good evening, respected moderator sir and other speaker. Discussion was very much comprehensive and very educational. And the first topic was I was at that time I was absent. First topic I think that was
DAPT, how short is short.
Yes. Actually, from our day-to-day practice, that according to guideline, there is no blanket therapy for DAPT as of now. So we have to judge the patient's risk factor number একটু পরে প্লিজ একটু পরে 2 মিনিট পরে প্লিজ আমি একটু মিটিং এ আছি we have to judge the risk factor of the patients and also the bleeding risk. So if patient is having high risk patient like a patient of MI and patient in having other risk factor like intervention with in left main bifurcation stent and also long segment stents given to the patient. So in that category, I think we have to continue the DAPT at least for 1 year. I think if there is no high bleeding risk. And then we have to continue single or dual according to our clinical judgment. At least we have to give 1 year. But in some patients, if in the meantime patient is having some bleeding or any fatal bleeding, then we have to shift to or we can shift to another only single antiplatelet. So in that cases, if patient is having high risk risks of bleeding, in that cases we can continue 1 to 3 months DAPT, then followed by we can shift to only single antiplatelet, preferably clopidogrel or ticagrelor, P2Y12 inhibitor. And this is, I think, this is my practice, and also this is the practice of Indian cardiologists, I think. And another point we can say in high risk patients, like patient having left main stent or long segments stent put on, patient having bifurcation stent, then if we have good imaging, then we can we are very much satisfied with our imaging that patient having good stent apposition and there is no residual thing. So in that cases, if we can follow up the patients, so in that cases we can give at least 3 to 6 months of DAPT, then followed by single antibiotic. But in our country, it is not. I think this is not very much practical, because in every case we can do this imaging. So this is our strategy should be. We have to continue at least 1 year dual antiplatelet, then we can shift to another single antiplatelet. This is, I think, for our country, it will be a good thing if there is no high bleeding risk.
Yeah.
And in the second topic, I think beta blocker in younger patients.
Young hypertension.
Hypertension.
Be short, because I have to invite Dr. Sanjeev Roy, and then we have to go to endocrinology.
So, beta blocker, I think if a younger patient, we can give beta blocker in those patients. If a conventional antihypertensive like SC inhibitor, ARB, is patient is having good control of blood pressure, then we can there is no need of beta blocker. But if patient is having heart rate more than 80, or their patient having symptoms of palpitation or any tachycardia, anxiety, in that cases we can add on beta blocker. And previously we were giving to atenolol or other beta blocker, but nowadays the choice is more selective beta blocker like nebivolol, carvedilol, and bisoprolol. So patient having more sympathetic overactivity with resting heart rate more than 80, in that cases we can give beta blocker with other antihypertensive like SC inhibitor or ARB, that will, or any calcium channel blocker. That should be the strategy in patient with young hypertension with tachycardia, because tachycardia having a marker for increased mortality and morbidity in this group of patients. And third topic is role of ARNI in heart failure with preserved ejection fraction. So it is class 2 recommendation, I think. And the basic thing is the diuretic if needed and SGLT2 inhibitors. And on top, we can give ARNI in those subset group of patients whom ejection fraction is borderline. I think heart failure with mid-range ejection fraction, at least 57% in that category of patient, because there is just lower in the lower ejection fraction group of patients with heart failure with ejection fraction. Number one. Number two, in female patient with evidence of heart failure with normal ejection fraction, in the female patient there is study that have shown already that there is increased benefit. And other group of patient, I think in patient with recurrent hospitalization, recent hospitalization within last 30 days, and patient with elevated BNP in spite of giving diuretics. In this subset of group of patient, we can give ARNI after giving the SGL2 inhibitors. So this is for the heart failure with ejection fraction patient group. And fourth topic is, I think, in the reverse remodel, patient recovered. That group, we can heart failure with recovered ejection fraction. The group already defined as patient having heart failure ejection fraction less than 40%, then improved with GDMT more than 40%. So in this group of patient, whether we should stop the GDMT or not, this is idea is very much clear that we have to continue our GDMT according to maximal therapy if patient can tolerate. We should not de-escalate or stop any disease modifying medicine. We have to continue the medicine. And because patient in heart failure with reverse ejection fraction, they have the remission but not recovered. So this is the basic thing, is that we have to continue our JDNT according to tolerance of the patient. Thank you, sir. That's, I think.
Thank you. Dr. Sanjeev Roy, are you on board? Dr. Sanjeev Roy. No, I think we are not having Sanjeev Roy on board. So thank you very much, all my colleagues and Dr. Ashraf, for summarizing the whole meeting. I now invite Dr. Gagan Priya, who is a consultant endocrinologist in Fortis Hospital, Mohali, to take over the endocrinology limb of the symposium. And once again, I welcome you, madam. And I'm sure we'll be benefited by your deliberation on a very important topic. ADA 2026 meets Indian practice, what fits and what shifts, because there is a lot of cardiology, endocrinology, nephrology overlap. This is a unique opportunity that we have an opportunity to learn from each other. Earlier, we were in our islands. Cardiologists were not meeting endocrinologists. Endocrinologists were not meeting cardiologists, nephrologists. So these drugs have put us together. Otherwise, we were all in our own islands and doing what we could do. Vascular continuity of the body has empowered us to sit together on top of these molecules, that they are vascular drugs. And that's why the opportunity to learn from each other is enormous, which is practice changing. So once again, I invite Dr. Gagan Priya, what fits and what shifts. Welcome, madam.
Thank you so much, Dr. Rajiv. I think we've had a very, very interesting and enlightening session so far. And, as Dr. Rajiv put forward, I usually often tell the story of the 6 blind men and the elephant. There is a story from old India, the ancient India, Buddhism. Its first features is somewhere in Buddhism texts. And this was about 6 blind men, wise men, who never knew what an elephant was. So they come across an elephant for the very first time. And each of them is, touching upon a different part of the elephant and trying to gauge what that elephant is. So somebody is touching the trunk and thinking the elephant is like a wall. Somebody touches the rope, thinks the elephant is like a rope because they're just touching the tail. Somebody is looking at the legs and thinking it feels like a tree, and they kind of start fighting with each other that you are describing the elephant in a wrong way. So the bigger picture actually is only appears when we start communicating to each other. So when the six men, in our case, it's cardiology, endocrinology. It also includes gastroenterology. Now we know that there is a gastric connect here. We also have the gynecologists involved with us where it comes to reproductive dysfunction, PCOS, and so on. The oncologist is involved because malignancy risk also increases in all of these syndromes. So we will look at it from the perspective of being, the six men or blind men or women who try to communicate and understand what this picture is. And for this session, we have two very interesting talks. One by Dr. Saqib Ahmed Khan. A warm welcome, Dr. Saqib.
Thank you.
And he will be speaking on ADA 2026 meets Indian practice. There have been some changes in the ADA 2026 guidelines. So let's look at that from perspective from Dr. Saqib Ahmed Khan. He is endocrinologist, a very dynamic and active person. He is working at Chandan Hospital in Lucknow. So, Saqib, to begin with, how is the weather in Lucknow?
It is, ma'am, cold, quite cold here. Actually, there was quite good weather for last 6 or 7 days when we were having the peaking of sun. But today only it was having a weather where we were not able to see even beyond 200 meters or so. Otherwise, it is still good. It is
200 in
becoming
progress.
better as compared to a
200 in
4 times.
progress from Chandigarh, where we had a visibility of 50 meters only.
Okay, ma'am. Okay, ma'am.
Let's hear you out. Thanks.
Thank you, ma'am. So thank you, ma'am, for your nice words and for this opportunity. So we'll be discussing about the one of the most sought guideline. We have guideline. We know that we are practicing when we talk about the type about the management these days. We talk about the evidence-based medicine, and on the basis of evidence we have a lot of guideline. There are actually to the extent of the confusion, but ADA is one of the guideline which is followed across the globe. So we'll be seeing that what has been updated in this year. So what is new in ADA 2026? There has been some comprehensive updates about the prevention diagnosis. We know that now we are not only talking about the treatment of a chronic progressive disease, but actually we have the chances of relapse or the remission also. Remission of diabetes when we are able to cut down the weight and we are focusing on the diet and lifestyle modification and the other things very intensively in the initial few years. The diagnosis, the treatment, the management. We talk about the holistic management, the importance of the comprehensive management, that we need to look into all the risk factor which the patient is having, and we are not only glucocentric, but we'll be talking about the cardiovascular and kidney health component, the digital therapeutic integration, which is having more and more say with the passage of time. We are having CGM, we have a lot of application which can help the patient and which can help the patient anxiety also, and help us to, when we are utilizing these things, precision medicine recommendations what has been updated. So diagnosis, when we talk about the gestational diabetes, when we talk about, there has been a confusion that when we should tag it, when the environment of a mother blood which becomes more diabetogenic after 24 to 26 weeks, then only we should label it, or before that if the patient is diagnosed, so we should have just a tag of over diabetes with which is diagnosed in the pregnancy. So in those who are diagnosed before 15 weeks with just some higher level like 110 to 125 fasting plasma glucose, which are not enough to label as the over diabetes, and those who are having HbA1c of 5.9 to 6.4, that tells us that we are having a higher risk of adverse pregnancy as well as neonatal outcomes, and we are having a higher risk of later development of gestational diabetes. Then we should be having more focused approach on those patients, and we should screen any patient after 24 to 26 weeks, so that we can know the any newer development of GDM even in any a normal glycemic patient beforehand. Those who were having gestational diabetes, they will be having a risk of over diabetes of 50% in their latter part of their life. For that, we need to screen them after 12 weeks postpartum using the 75 gram OGTT. At least 1 to 3 years screening for the development of prediabetes or diabetes would be required for lifelong for the risk of diabetes in them. For the purpose of drug-related diabetes, we talk about the no diet or the new onset diabetes after transplant, or the diabetes with drugs like with mTOR inhibitor, PI3K inhibitors, the combined inhibitors, as well as glucocorticoids. So we should always be having these facts in our mind, that when the patient would be taking these drugs for CML or any other reason, which is a very common practice these days, the patient might be having a severe hyperglycemia in a normoglycemic patient, and those who are having diabetes, they would be having a very severe exacerbation, and that should prepare us before the start of treatment or when the treatment is started, so that the outcome can be better. Use of metformin as a first line treatment for cancer drug induced hyperglycemia has been put forward. In those who are having a severe hyperglycemia, insulin therapy is the gold standard. For those with pre-existing diabetes, we should expect the worsening of hyperglycemia. We should treat them accordingly. The prevention or delay of diabetes and associated comorbidities. So we were previously talking about the purpose of diabetes as the prevention of complication, but now we can even prevent we are talking about the chances of having prevention of progression from pre-diabetes to diabetes, as well as the remission also. So how we can do this? So we need to look continuously. We are having those tools like CGM is not only a diagnostic tool, it is a therapeutic tool. It can help the patient. It can also actually let the patient know that how the patient is behaving across the day, what is the impact of their activities, and thereby it also pushes the patient for intervention, that it is having a reward also when the patient is walking, when the patient is having the healthier food. So it can not only be used in those who are having the over diabetes, but also in pre-diabetes, and its use is being expanded. How, when we are knowing that the patient is having pre-diabetes, we can prevent from progressing to type 2 diabetes. The diet and lifestyle modification has been proven to be the most important aspect from the diabetes prevention program also, and at least a weight reduction of at least 5 to 7% of initial body is required, and that has been updated in this guideline also. Diet is the most important aspect with the strongest evidence base for preventing type 2 diabetes, though a lot of ways can be adopted like Mediterranean diet or low carbohydrate, which can be providing us a hypocaloric diet. Technology assisted diabetes prevention program are encouraged. There are many available on the web-based application. So we talk about a disease where the purpose of treatment is prevention of complications. So we look from the very onset that what risk factor the patient is having, what social support the patient is having, and we come to a mutual consensus that what should be the goal. Metabolic dysfunction associated steatotic liver disease, which was previously known as the NFLD, was added to be considered as a specific factor that also impact the choice of treatment, because we know that the reason of decompensated liver disease uh, is this after the hepatitis and alcoholism. Those where we are dealing with this MASLD and where we are performing a FIB-4 score, which can be easily done on an OPD basis, and when it is more than 2.67, they should be treated with the with an interprofessional team where the gastrophysician or liver specialist should also be involved. When the stiffness marker is more than 8 kilopascal, then also we should be having this concern. The GLP-1, especially the semaglutide, has shown the benefit. We are having very less option. We know that in those who are having a biopsy proven NFLD, we are only having the pioglitazone, which also is required in a lot higher dosages, which we use in our practice, and with that comes the weight gain and those things. But GLP receptor agonist offers both these benefits. As the fibrosis progresses, then the usage of these obesity pharmacotherapy and diabetes pharmacotherapy decreases, and we should use them with caution as the fibrosis increases. You can see from uh, up to low, and when the patient is having a decompensated cirrhosis, we should be very vigilant about further losing the weight, because the patient would already be having the cachexia. The usage of insulin in decompensated cirrhosis is a more predictable option, which can help achieve our goals. How we can facilitate the positive health behaviors and well-being to improve health outcome, when we have already seen that the diet is the most important aspect when we want to not only control but also we want to prevent the progression from pre-diabetes to diabetes. So there are a lot of ways by which the patient can be motivated to do to inculcate the healthy habit, like some of the religious fasting. They also are prescribed in the religion, like in Jainism, like in Hinduism, like in Muslims. We can promote them, but we should promote them safely. We should assess them at the start of their at their commencement, and then only we should uh, prescribe the right kind of prescription to them. The intermittent fasting, which is also having a lot of benefit, and it is a more flexible option where the patient is not uh, forced to continue it for a specific period of time, where the patient can stop. So there it is actually more safe also, if we are prescribing it to our patient, so we can use them. When we talk about the other health related uh, issues, like any abuse, like when the patient is having tobacco, now it has already included the cessation of e-cigarette also, because vapor is also not having the uh, having risk free. So it is also a behavior which should be counseled against, and we should take the help of pharmacotherapy to have uh, mm, to have a cessation of smoking in any patient who is doing it. Diabetes technology. So it says that CGM, which is now recommended at diabetes onset and anytime thereafter for children, adults, and adults with diabetes who are on insulin therapy and are also on non-insulin therapy. And the intermittently scanned CGM is no longer discussed in that study, which is a kind of older version according to them. Obesity and weight management for the prevention and treatment of diabetes, which is the hot topic these days, because now we are having those options which can have the amount of weight loss which were only possible with the bariatric surgery, like 20 or 30% beforehand. So we must diagnose an entity, then only we can treat it. So how we can diagnose it? Not only the BMI, which can have which can mislead us in many a time, but the waist hip ratio or some other direct measurement like DEXA, which is not a very practical approach though, but bioelectrical impedance analysis also gives us a bit more picture about the muscle and the weight distribution in a patient. And when we have identified that the patient is having more weight, then weight loss of at least 5 to 7% of baseline is a helpful tool in helping the patient, and a sustained weight loss of more than 10% is having a more greater benefit with the disease modifying effects on not only diabetes but also on osteoarthritis, knee, the obstructive sleep apnea, and a lot of other mechanical and metabolic complication of obesity. Not everyone would be requiring the highest dosages. the maximally tolerated dosage, which is doing good enough, should be reached. It is not that every patient would be requiring the maximally approved dosage. So what is the pharmacologic approaches to glycemic management? It is not a very drastic change, but yes, it has been revised to include a dual GIP and GLP-1 receptor agonist, or the tirzepatide, and or the GLP-1 receptor agonist for glycemic management for those with type 2 diabetes along with symptomatic heart failure with preserved ejection fraction, for which we are having very less tool. We have previously found the SGLT, now we are having this tool also, or metabolic dysfunction associated cirrhotic liver disease or MASH and obesity. So for this, we are having some of the tool which are having a very high efficacy like semaglutide or tirzepatide for weight loss, some high efficacy option like dulaglutide or liraglutide. Like we are having those options which are not, which are having very high anti-hyperglycemic efficacy after insulin, like dulaglutide in higher dosages, which are which is more than 1.5 milligram up to 3.5 4.5 milligram, which is not available in our country. Semaglutide, tirzepatide, insulin combination. So if the patient is having a very high glycemic load, and we need bring this down rapidly, and the patient is symptomatic or is catabolic, so accordingly we can use the insulin or those high anti-hyperglycemic efficacy options. In those who are having heart failure with preserved ejection fraction, CKD or transplant, for heart failure with preserved ejection fraction, the dual GLP-1 GIP agonist receptor agonist and GLP receptor agonist, they are useful. We need to initiate and continue this. We can now continue SGLT inhibitors if safely, even when the GFR is less than 20 and the patient is not put on dialysis. In those where the transplant related diabetes has been diagnosed, or the NODAT, which we say, the DPP-4 can be used for mild hyperglycemia because of their very safe profile. They are next to placebo in their side effect profile. But when the patient is having the higher blood glucose levels, GLP-1 receptor agonist, especially for their cardiometabolic benefit, can be added. And if the patient is not able to obtain their goal, insulin is always a choice which can meet our goal. Cardiovascular disease and risk management. We talk about the ABC, the A1C, the blood pressure, the cholesterol or the lipid management, and now the cardiovascular and kidney benefit. So we know that if the patient is a suitable candidate in a non-pregnant patient, the ACE or ARB, along with that, we should target the blood pressure goal of less than 120 if it can be tolerated in those who are having the high cardiovascular or kidney risk. Those who are, so actually there are stalwarts of cardiology already, so I'm not going to detail that, but yes, we are having the on top of the standard of care, the maximally tolerated ACE and ARB, the ARNI or the beta blocker or the MRA with demonstrated benefit in those who are having reduced ejection fraction. So GLP-1 receptor agonist is also an option which can be added, especially in asymptomatic heart failure with high risk of or established cardiovascular disease. So not only SGLT2, but GLP receptor agonist is also a very good option, and they both can also be combined to give an optimal outcome in this regard. Non-steroidal mineralocorticoid antagonist with proven benefit is also recommended for stage C heart failure with preserved ejection fraction and diabetes for their benefit in mortality. No fibrate, niacin, or omega-3 fatty acid supplements has shown to reduce the final outcome, so they are not encouraged. The GLP-1 receptor agonist is included for type 2 diabetes and CKD in the management. So how frequent it should be in any type 1 diabetic patient for after diagnosis? after more than 5 years, every patient should have at least annual GFR and at least a random urine albumin creatinine ratio assessment. Simultaneous initiation of SGLT plus non-steroidal mineralocorticoid receptor antagonist can be considered in type 2 diabetes with albumin creatinine ratio of more than 100 on background of RAS blockade. So it can give the maximum benefit to the patient, the RAS blockade along with non-steroidal mineralocorticoid antagonist with SGLT. SGLT can be continued even below 20 when it has been initiated when the GFR was more than 20. So a holistic approach that the diet and lifestyle, the glycemic management, the statins, they all need to be taken care of when we talk about the diabetes and CKD outcome, not only the cardiac outcome. So in terms of retinopathy, neuropathy, and food care, we have this discussion, though there is hardly more than 7 to 8 cases of non-arthritic non-arthritic ischemic optic neuritis, for which can lead to the dreaded permanent blindness, but still it has been associated, but it has not shown to be a causative agent. So the relationship between any GLP-1 receptor agonist and these retinopathy complication like this and neovascular age-related macular degeneration is still not very strongly linked. Like there is a conflicting data regarding this. All the GLP-1 receptor agonists, which actually any therapy which can reduce the hyperglycemia very rapidly, is having a risk for exacerbating the initial worsening or the initial worsening of retinopathy, which we should be cautious about. So it is not only for this dual GLP-1 and GIP agonist or the newer stronger injectable GLP-1 receptor agonist like semaglutide, but it has been associated with any other GLP-1 receptor agonist. Neuropathy specific recommendation, we can start with the individual option, but those who are not responding, a combination of these medications can provide an additional relief. And also the emerging evidence also says actually strongly that GLP-1 receptor agonist therapy based therapy is actually able to reduce the lower extremity amputation. There has been some initial data like these papers which has shown that treatment with GLP receptor agonist may reduce the risk of lower extremity amputations, distal diabetic foot ulcer, and all-cause mortality compared to the children uterus. We were having initial skepticism when the assumptor like canagliflozin has shown the more risk of amputation, but now we have the other ACVD beneficial option, the GLP receptor agonist, which has shown that it can be actually good in peripheral arterial disease. Like oral semaglutide had a significantly lower rate of major adverse limb events in the designated cardiovascular outcome trial, and semaglutide also improved the walking function in people with peripheral arterial disease and type 2 diabetes, including individuals without obesity and those with well-controlled HbA1c also. So
Dr.
we can
Saket,
shift.
can we end this in 1 minute because we're
Yes,
running?
ma'am, yes, ma'am, yes, ma'am, yes, ma'am. So just to summarize, the 2026 guideline expand the usage of technology. We should not only restrict to those who are just on the basal bolus insulin, but it is a therapeutic tool. Those who are known to have the hyperglycemia, like mTOR inhibitor, PI3 inhibitors, whose usage is increasing, we must prepare ourselves to deal with the hyperglycemia which is yet to come. MSLD is explicitly added as a factor driving the choice of treatment in type 2 diabetes in those who are having the preserved ejection fraction, and MSLD or MASH, the GLP-1 receptor agonist and the dual agonist has shown benefit. It suggests that adiposity assessment beyond BMI in obesity needs to be taken care of. New policy remove some previous prerequisite, making continuous subcutaneous insulin infusion difficult, so it is more accessible these days. So these were the some of changes or some of the newer discussion, especially in the ADA 2026.
Yeah. Thank you, Dr. Sakib, for taking us very elaborately through the changes that have happened in ADA 2026. And as you can clearly see, we are moving away from a glucocentric approach to a more organ protective holistic approach. And with that, we'll move on to the next speaker, that is Dr. Akash N. Shah. Dr. Akash is a consultant endocrinologist at KD Hospital, Ahmedabad. So Dr. Akash will be speaking on metabolic syndrome in the young. So, it was a disease of 40s and 50s, but now we see more and more metabolic syndrome in even 30-year-olds. In fact, by 30, even 15 and 20, we are seeing metabolic syndrome. So I'll invite Dr. Akash to take this forward.
Hello, ma'am. Good evening. I hope I'm audible and visible enough.
Yes, we are just waiting for your slides to start showing.
Right. So thank you so much for this wonderful opportunity where a great amount of discussions have taken place, and I am very grateful to all the different speakers, seniors over here. And we have already discussed a lot about all the secondary and tertiary preventive care. But when it comes to primordial or primary, it is still an area where our discussions are not that frequent. So this is more of a primary prevention for cardiovascular diseases. Right. So just give me a moment. I think my slides are visible now. So as the title suggests, metabolic syndrome in the young is 30 the new 50, right? There have been a lot of factors which have influenced our lifestyle, our choices of foods, our choices of different kinds of entertainments and web-based applications which have made food access even more easier now, and a lot of sedentary lifestyle that might lead to a lot more metabolic syndrome. So what is metabolic syndrome? Just brushing up our existing knowledge. So it is kind of a cluster of abnormalities which are characterized by the common factor is insulin resistance, and ultimately there is higher risk of development of type 2 diabetes and cardiovascular diseases. So it encompasses various factors which include blood pressure, triglyceride level, LDL, HDL level, fasting plasma glucose, central obesity as per the waist circumference or BMI in certain criteria. So the two commonly used criteria include WHO and ATP3 definition for metabolic syndrome, which we will discuss in upcoming slides. So metabolic syndrome in young, already WHO has recognized it as a global epidemic, which is a major healthcare problem. And, among certain studies, it has shown that more than a third of Americans over the age of 20 years are already affected by it. Almost 10% of adolescents are affected, and prevalence increased to 44% among those who are obese. Right. So Indian scenario, there have been a few studies, one particularly interesting, which showed the differences across various urban, semi-urban and rural population. So there we can see urban population, as we can expect, higher metabolic syndrome prevalence has been documented across various communities and states. But we can see that almost 1/3 to 2/3 amounts of abdominal obesity, hypertriglyceridemia, low HDL, hypertension and raised fasting plasma glucose. An important thing to notice, almost 2/3 of population had low HDL. So this is one of the risk factors which has probably the highest overall prevalence. And community-based studies from Eastern India also showed around 31% of metabolic syndrome prevalence. Females being more affected, almost 48%, males having 16%. Rural population as compared to urban, lesser prevalence, but still it was seen in around 9.3%, and semi-urban somewhere in between, where around 30% individuals were shown to have metabolic syndrome. Now, coming to the aspect where we are talking about metabolic syndrome in young and how prevalent is it. So there have been again different kinds of studies. Lately, our interest has been higher and higher in learning what are the patterns in younger individuals and what happens over a period of time. So first aspect is what is the existing pattern in younger population. So a population-based study where more than 2,000 healthy individuals aged between 24 to 39, apparently healthy individuals, right, were enrolled in the study. And the metabolic syndrome and its components were studied as per the NCP definition. That includes waist circumference, above 102 centimeter for male and 88 for female. Serum triglyceride 150 mg per dl cutoff, HDL below 40 for male, below 50 for females. Blood pressure cutoff 130 by 85 millimeter of mercury, and fasting plasma glucose more than 100 mg per dl. So, as per the different criteria used, we can see in the population study that when you move from lower to higher age groups, the prevalence of metabolic syndrome goes higher and higher, irrespective of whatever definition that you use. But we can clearly see that with NCP definition, probably 13%, and other definition 10% and 15% respectively. So, this secular trends suggest that a dramatic increase in the prevalence of metabolic syndrome is seen when you move from 24 towards the 40 years of age, right? Now, again, different recent studies and larger data. So this was a pooled analysis study where more than 26,000 participants were studied from 34 different studies, and they were studied using various different defining criteria. The predominant entry criteria for the age was 18 to 30 years, and apparently all the healthy individuals were enrolled. So considering the different, we can see different kinds of bars, and on the x-axis there are different the components of metabolic syndrome, and we can see the bars labeled as defined by harmonized criteria, IDF criteria, NCP ATP3 criteria, or AHA criteria. So here also HDL level, low level of HDL below the cutoff is the highest prevalence, and then we can see different other cutoffs. So overall metabolic syndrome prevalence here also was significant, around 5 to 7% of young individuals. So that's quite alarming in a way. And low HDL again becoming the most prevalent one. So whenever you come across your family member or a health checkup patient, right? Health checkup individuals in various corporate hospitals, they are mostly healthy individuals, and that's where we often pick up low HDL, but we do not have any means to treat HDL directly, and that is probably one of the most ignored markers. But if it is there, then you may consider that individual to be on the higher risk of developing metabolic syndrome over a period of time. So, considering the implication of early pickup, right? So we have seen that metabolic syndrome patients have almost 30 to 40% of probability of developing CAD within 20 years, depending upon the number of existing components. So here in the graph, we can see as the number of risk factors increase, right? So the bar diagram indicates the frequency of presence of any risk factor. So we can see around 2 is the peak of individuals with risk factors, and the line chart shows the cumulative risk of developing young CAD. So as the number of risk factors go high, the risk for developing young CAD goes higher and higher. So, screening of young, apparently healthy individuals and young CAD patients for metabolic syndrome and its components may be rewarding for early case detection and early targeted therapy. So the main obesity is the central concept here, and we can divide it into different kinds of complication. One would be regarding the glycemic control, pre-diabetic or diabetic, another about the atherogenic dyslipidemia, and another about the higher blood pressure or hypertension. So this is a very concise and basic understanding of metabolic syndrome, right? About 85% of type 2 diabetic individuals in this particular study were found to have metabolic syndrome, and these are the individuals who are at higher risk of CAD. So what are the overall risk factors, right? So increasing age, 40% of individuals over the age of 60 probably have metabolic syndrome. Certain races, Hispanic and Asians, are at higher risk. Low birth weight is a probable risk factor. Early menopause or gestational diabetes, again, risk factor. Lack of exercises and obesity, hypertension, existing hypertension, diabetes, stressful lifestyle, poor dietary habits like the sugar sweetened beverage consumption or processed food consumption in higher amount, sedentary lifestyle, and markers like triglyceride and HDL level. So these are all risk factor for development of metabolic syndrome. And risk factor for type 2 diabetes in young individuals with metabolic. So going one step ahead, once you have identified those all who have metabolic syndrome, how do you predict who are all going to have higher risk of type 2 diabetes? So again, higher visceral adiposity, inflammation and oxidative stresses, higher free fatty acids and tissue insulin resistance, some amount of role of puberty, ethnic variations, perinatal factors and insults, females, especially those with PCOS and metabolic dysfunction associated steatotic liver disease, MASLD, a disease which we have known for a very long time. So considering the basic pathophysiological aspect, as we know, there are multiple effects of visceral adiposity that leads to alterations in the inflammatory pathways and certain metabolites. So it leads to more of a pro-inflammatory milieu where along with the visceral adiposity, the genetics, the overall lifestyle, the overall calorie intake, this all lead to more of chronic inflammation, hormonal disturbances, insulin resistance over a period of time, and converting into metabolic syndrome. And what is the correlation of metabolic syndrome with the cardiovascular outcome? So all the different components of metabolic syndrome, even as individual components, lead to some adverse effect on the cardiovascular system, and that includes arterial hypertension, atherosclerotic cardiovascular diseases, and higher risk of sudden cardiac death and myocarditis. So this link is already well known, right? So that gives us an edge to act on metabolic syndrome. And again, coming to different inflammatory markers, so different kinds of pro-inflammatory markers go high, and different kinds of probable beneficial inflammatory markers go down significantly in those with metabolic syndrome. Some of this, like IL-6 and TNF alpha, have direct contribution towards rising insulin resistance or rising free fatty acid levels and ultimately diabetes. So this is again a wonderful, concise food image where abdominal obesity may lead to hypertension, dysglycemia, and atherogenic dyslipidemia, and this ultimately leads to end organ damages and clinical manifestations or recognizable disorders like impaired renal function, fatty liver disease, and further progression, heart failure with preserved ejection fraction, say PCOS, sympathetic overactivity, tachycardia, hyperuricemia, and chronic inflammation. So the diagnostic criteria, right? There have been certain differences across different societies, but the general concept remains more or less the same, where this particular study, and particularly this Polish studies and guideline regarding metabolic syndrome, they have used recently this criteria. Now, why is this Polish study so important? Because from a genetic perspective, Polish population, they are considered to have high risk of cardiovascular disease. So any early risk factor identification and prevention or treatment might be, a larger conversion towards primary and secondary prevention. So here, what we consider is one clinical anthropometric aspect, that is abdominal obesity, waist circumference 88 or 102. Sorry, here it should be men, and BMI criteria of more than or equal to 30 kg per meter square. Additional diagnostic criteria on top of anthropometry. So either glycemic parameter, pre-diabetic, impaired fasting glucose, or non-diabetic on medications. Then the lipid aspect, non-HDL cholesterol level more than or equal to 130 mg per dl, or someone already on lipid lowering medications. And then another would be blood pressure criteria. So 130 by 85, either office monitoring or ambulatory monitoring, or someone on antihypertensives. So this is a basic framework. How do you utilize an algorithm to better pick up and manage? So first you look at the anthropometry, which is very easy to assess or even screen an individual walking in your clinic. So based on abdominal obesity or BMI criteria, you consider whether you want to go ahead with blood pressure, fasting glucose, and lipid cholesterol level monitoring or measurement initially. If the person does not fit into criteria, if the person fits into criteria, of course, it's very clear. If the person does not fit into criteria, You consider the next line of evaluation that includes oral glucose tolerance test, urine ACR level. Microalbuminuria is also a part of definition of metabolic syndrome. Then abdominal ultrasound, liver function test or liver enzyme assessment and uric acid assessment. And then further, as if needed, if the patient's clinical conditions warrant evaluation further, you consider for echocardiography or NT-proBNP, BNP level, then liver elastography or biopsy, polysomnography or serum androgen level for females especially. Now, moving on to the next aspect, the trajectory of metabolic syndrome. So once we pick up younger individuals, now we are curious about what happens to them over a period of time, right? So if we can pick up or identify a particular group of individuals where the outcomes would be beneficial and where the outcomes would be grave or early CVD. So that's what we are interested in. And then again, learning about the various risk factors, modifiable and non-modifiable, and its effect on the outcome, right? So again, for this population from a study, cardiac study, which is a multicentric longitudinal study designed to track the development of CVD risk factor in USA in apparently healthy 18 to 30 years of individuals. Right. So this gave us a great opportunity to learn about the outcomes. So on the y-axis here we have number of components of metabolic syndrome present in an individual. So we can see at younger age around 25, probably only no risk factor or only one risk factor in most of the individual we would expect. And as these individuals um, grow older and older, the outcome is studied here. So we can see that those who did not have baseline risk factor probably maintained the same kind of phenotype, whereas those who had higher risk factor, they continue to have worsening, especially till the age of 30 years or so. And then over a period of, and we can see that there was a higher risk of metabolic syndrome ultimately in that subgroup. So this indicates that probably early life, somewhere around 25 to 35, would be more critical to act more aggressively in an order to have higher primary prevention goals achieved. Now, treatment algorithm, a very concise algorithm here about managing metabolic syndrome. So we can break it down into various components: obesity, dysglycemia, hypertension, dyslipidemia, and work on all of it. So the common strategy would be regarding dietary management, lifestyle modification. Dietary management includes reducing simple carbs, reducing processed foods or trans fat, saturated fatty acids, increasing omega-3 fatty acids, reducing salt intake, calorie reduction in order to achieve better weight, increase physical activity that could be low, moderate intensity, 150 to 300 minutes a week, or higher intensity, vigorous intensity exercises, 75 to 150 minutes a week, and moderating alcohol intake, cessation of smoking, and sleep hygiene maintenance. These are all essential basic criteria applicable for all the individuals who have metabolic syndrome. Now, as you go ahead, as there is further categorization of each component, as you consider obesity, various stages, and dysglycemia, hypertension, and dyslipidemia, various severity of your parameters, you consider treating accordingly, be it just non-pharmacological or stepping up pharmacological aspects. So this is about the basic lifestyle dietary modification. So the most common recommended dietary strategy is the calorie deprivation. You reduce by 500 to 600 calories per day, and then you further try to. So that is the initial target, and then you build on it. Then you try to counsel patient over a period of time to put more and more efforts to achieve a desired target weight or ultimately desired target metabolic parameters, and then having more or at least adequate omega-3 fatty acids, EPA and DHA in your diet or through supplements, focusing on the glycemic index, moderate to high protein diet, especially for Indian population where carbs probably two-thirds or even higher in a good number of individuals, right? So they are cut to almost 55%. increasing proteins to 15 to 20% or even higher at times when you want higher weight loss, and maintaining fat to around 20 to 30% in your meal intake. So that would be more. Ask the patient to consume frequent meals and smaller portions rather than one or two large meals a day. Uh, and Mediterranean diet might be beneficial, but again, there are a lot of controversy, or we do not have that strong evidence to recommend only one kind of diet. Again, diet is something where people are very much choosy at times, so you have to be mindful about what all you are recommending. But this is again an important guideline table where you are trying to adjust the calories as per the desired weight or prevention of weight gain, and portions, carb, proteins, and fats should be maintained. Saturated fat should be low, below 7% of total calories. And again, micronutrients also you need to focus on. Dietary fibers, very important part. So this is a very important table which we need to try to utilize as and when possible and teach, educate our patients. Pharmacotherapy. So drugs, as per the individual complication or individual uh, disordered state. So for hyperglycemia, dyslipidemia, and hypertension, we all know various kinds of groups of agents, but considering the basic aspect of underlying metabolic syndrome, what all agents might be more beneficial. So when we are talking about insulin resistance, probably metformin, thiazolidine, pioglitazone would be scoring higher as compared to many other groups. And again, GLP-1 analogs might be beneficial or would score higher because of their certain characteristics acting on the insulin resistance pathway. So that is something which you need to understand and employ accordingly. Uh, Lipid lowering therapy. So statins continue to remain our first choice of therapy, and LDL target range differs as per the risk category of the individual. So CVD risk categorization should be done in almost all patients, and you try to choose your targets, you try to amplify your treatment accordingly. When it comes to antihypertensive therapy, there are certain negative or adverse effects with diuretics and beta blockers, ultimately increasing the risk of insulin resistance or metabolic syndrome a bit. So here AC inhibitors and ARBs score higher. And we have adequate studies, adequate evidence through HOPE study where ramipril showed significant reduction in CV death by 26% in patients at high risk as compared to placebo. And again, risk reduction of MI, stroke, and CV death were also significantly high. Same with losartan, also we had significant higher impact. So ACARBs in general, they have higher vascular and renoprotective effect. Now, important thing which we need to consider about the use of aspirin. So there are still certain controversies, and we need to individualize our treatment. So consider those who are at a bit of high risk of bleeding related complications. Maybe you may not consider utilizing aspirin all the time, but then in general, metabolic syndrome is a prothrombotic state. Elevated plasminogen activator inhibitor 1 and fibrinogen levels are there. So lower dose of aspirin might be beneficial in prevention of further aggravation of ASCVD. So high risk individuals should be given the advantage. And again, higher level of CRP or HSCRP may be there. Again, uh, revealing the pro-inflammatory state, but no specific treatments are available at present. Obesity, the much talked about element these days, we diagnose it through anthropometric measures, and then there are multiple medical, functional, or mental domains, the impact of obesity on various aspects, and then we decide the treatment pathway. So it's always an ongoing discussion with all our patients where we try to consider, we try to be realistic about targets, we try to discuss the importance and benefits of achieving a better weight or losing weight. And we consider intervention accordingly. That includes lifestyle intervention along with plus or minus pharmacotherapy. Food intake regulation, now something which is very useful for all of us. That brain has got various areas regulating food intake, and there are different kinds of eating pattern. The homeostatic eating and hedonic eating. Hedonic is the pleasure eating, pleasure linked eating, and homeostatic is more driven by hunger. And then there are various
external cues and internal cues through hormones and signals, which ultimately impact the outcome or impact the choices of food, right? And then there is the executive area of the brain, which
Can we
is the
summarize now?
captain, which leads to, right. Okay, ma'am. Yeah. So anyway, we do have a lot of anti-obesity medications now. So to summarize, there are several evidences indicating a strong association between metabolic syndrome and younger adults. So we need to focus more on this aspect. Certain mechanisms are still not very well understood, but insulin resistance and visceral obesity still remain the central part of it. So this chronic inflammatory state, pro-inflammatory state is there, and CVD risk goes higher and higher. So we need to hit early, hit hard, lifestyle intervention, dietary intervention, good amount of exercises, and pharmacotherapy as and when needed is something which you need to consider more often. Thank you so much for patient listening.
Thank you, Dr. Akash. I think excellent talk on metabolic syndrome in the young. Of course, it's a major, major challenge now. And metabolic syndrome in the young actually seems to be a bigger problem. You know, the traditional thing was, you know, people with metabolic syndrome at 30s or maybe even 25. Let's just go with lifestyle. Let's keep telling them that. But now we understand that the prognosis for these people actually is worse than for somebody who gets metabolic syndrome at 55 or 60 or even 50. So with that, I'll welcome Dr. Shivender Verma to the discussion. Dr. Shivender is an assistant professor of endocrinology at SGPGI Lucknow. Warm welcome, Dr. Shivender. And thank you for staying with us till the end of the session. So, Dr. Shivender, we've had some very interesting discussion about drivers of metabolic syndrome. And of course, we often blame eating. There is increased junk food intake. There's more sedentary, less physical activity as one of the risk factors for these disorders. But, you know, in recent times, we also see people having altered sleep patterns. Sleep deprivation has become a major problem, and circadian misalignment. Late eating patterns have become very common. I think even people who don't need to eat late are having dinners at around 11, 12, and breakfast late that way. And then, of course, we have the shift workers, or especially the IT professionals who are working on a foreign clock and, you know, working in different shifts. So what is your take on the role of sleep deprivation and circadian misalignment in metabolic disease?
That's actually a very complex question you have asked at this point of time. And yes, both of these things are very important. And in most of the younger individuals, these are the things which cannot be avoided. Like the young people who are working for their US clients or other clients, they have to do the night shifts. Most of the young generations are generation guys, the Gen Zs are involved in multitasking, multiple income generating things they are doing. So we can't say that they should be off, they should find free time for them, they should do that or that thing. This is the real stress that is coming. And yes, we do find this is one of the contributory findings for not only the metabolic syndrome, obesity, or other things, even some of the endocrinopathies are also coming in this younger population because of these two things. So, yes, this is pretty much important. And as far as parents are considered or we are considered as part of the physicians, we should try to counsel that to minimize these things. Of course, we cannot negate or completely tell them to be off. And the stress level is too high. The younger generation may have other problems also apart from their careers. So we should try to address. And many a times, like young ladies coming with PCO, we just treat them as endocrinologists. So just sometimes it is required to have a pause and discuss with them. There may be a lot of interpersonal issues that may be going on, and that may be the root cause of those problems. So definitely we should try to address these problems beyond being just an endocrinologist.
So just beyond diet, exercise, and other things. We need to delve more. And I think you very rightly pointed out that the psychological factors we don't really talk about or discuss very freely. And psychological stress of any kind will also worsen cardiometabolic disease, and we need to address that. With that in mind, Dr. Sakib, one question only because of paucity of time. We talk of diabetes distress. People, there are, varied groups of people. Some don't really worry about being diagnosed with diabetes. They're living healthy, living fine and happy. But there is a subgroup who's really anxious, who gets overwhelmed. So, what, according to you, is diabetes distress, and how can we address that?
So, diabetes distress, as you have said, is a condition which is different from anxiety or depression, which can come with any chronic disease. In it, definitely, patient think that he is overwhelmed. Apart from the other challenges, like Dr. Shivan Verma is saying, that the challenges of the era, he will have to have a focus on this chronic condition which is not going away. So first question would be that how long we will have to have this dietary restriction or this OHAs or the insulin or the frequent up titration of the previous therapy which has failed, so that the patient is failing themselves is a thought which comes to the patient's mind. And if the patient is not having a good support system, so we'll have to have, like we have seen a slide which is showing that the social support is very much important to be assessed even at the time of diagnosis, at how much support of the patient, of the family or of the surrounding or the family or the friends is available to the patient, how much resources the patient is having. So how so and you will have to have a discussion at least for the first time, and you will have to keep monitoring those things, like PHQ-9 is one of the thing which I found useful. Like it can at least tell us that it can actually cool down the patient, that these are the things which you are having. And for last 2 weeks, if you are having these problems, you are having these symptoms. So if you are not able to do this, it is absolutely okay. But taking not help in those things which is making you less productive is definitely a thing which can make your outcome bad. So it is absolutely okay to have these things. It is so we'll have to accept it first, and then only we can actually encourage the patient to perform better, to cop these things better, to promote the the mental health, to inculcate those healthy habits. So if we are doing it slowly after identification, then we can minimize at least these phenomena of diabetes distress and those things which comes with chronic disease like diabetes.
So I think a healthy dialogue in our clinics, it should begin from there. We should bring it up proactively, and then of course look for support systems within the family, within friends and circles. Dr. Shivendra, we've talked about metabolic syndrome at length, and we've talked about the comorbidities which are a component of metabolic syndrome. So at what point do you think we should start pharmacotherapy? So we've heard from Dr. Akash, but do you think we should start it early before it really progresses into, diabetes? Do we treat metabolic syndrome as a pre-disease state or actually a disease state?
Yeah, so that is actually a difficult question to answer because the metabolic syndrome, if we dissect, there are many components of it, like pre-diabetes is there, hypertension, and dyslipidemia, uh, particularly the high triglyceride and low HDL, and the central adiposity. So we can easily cater this pre-diabetes or diabetes as far as guidelines are considered. As per the age of the patient, whatever the medications are approved, we can give definitely. There is no problem. And second thing is hypertension. Of course, the hypertension guidelines are there, and medications are easy to choose depending upon the comorbidities, presence of other things. And the problem comes with the other components, how to treat dyslipidemia, because no established guidelines specifically for less than 40 years of age. We don't have any guideline which suggests a primary prevention treatment, particularly with the statins, can be given. Even ASCVD risk factors or other risk factors are also not validated for this population. So we have to think of our like clinical judgment. If the diabetes is there for long duration along with multiple other risk factors, then we may think of adding these statins. Of course, that Dr. Shakib pointed out, or Dr. Akash has said that there's no use of, as of now, for fibrates or niacin for prevention of cardiovascular things. So there are definitely those drugs are out. Regarding adiposity, again, the lifestyle interventions will be key for these patients. And Indians, by default, are 10 years earlier in all the complications. Like all diabetes comes 10 years earlier, the CAD comes 10 years earlier, osteoporosis also comes 10 years earlier. So we have to be much more careful. I think we lack the guidelines in this regard, and we have to think of generating more data from our population itself.
And I think it's high time we start thinking of, even the 30-year-old as a very
Yeah.
high risk person.
So one
It's
point,
not
ma'am.
uncommon to see CAD at 30 years. Like we've heard of
Yes,
those incidents. Yes,
so
Dr.
common, so
So
common.
actually, when we actually dissect
And even
the
triple
this
vessel
prevention
disease.
program also, so we have seen that in those who are having pre-diabetes, and we are treating them for prevention of diabetes to be developed in those pre-diabetic patients. So diet and lifestyle modification is more useful in elderly patients, and metformin, and still in younger patient, the only diet and lifestyle modification is not going to be sufficient in most of the patients. So in those patients who are coming in with earlier age, especially in our population, I think metformin or the pharmacotherapy along with diet and lifestyle modification is having a more role when we
So
talk.
that will bring me to the question, why are we so hell-bent and stuck on metformin alone? Why not GLP-1
No,
in this scenario?
yes, actually any pharmacotherapy,
Right.
like we are having evidence of, yes, but any therapy which can actually bring down
So
the
if you look at the evidence for metformin, the diabetes prevention trial showed that, not the Indian program, but the Western program did show that metformin was less effective than lifestyle changes.
yes,
But now you look at the data for GLP-1 RAs, normoglycemia, remission of even
yes,
pre-diabetes has
yes,
happened. It's not progression of diabetes has been prevented, remission to normoglycemia has
yes.
happened. So I think we'll probably look at this in the coming future from a different lens. So last question for Dr. Shivender. So considering GLP-1 RAs, where do you place them in the management of, diabetes with or pre-diabetes with obesity? Do you think it's time we start offering patients therapy with GLP-1 RAs?
Yes, if given the choice, if there are no financial constraints, yes. In almost all patients, I would put my patients on GLP-1 analogs, because this is the drug, apart from SGLT2 inhibitors, which has some of the disease modifying abilities, not only for diabetes per se, the remission you have talked about, but also for the future cardiovascular complications. So definitely, if the choice is given, if there are no constraints, of course, the main thing is the constraints which we have now. We are hoping that in the upcoming months, we will have much wider application of these drugs. Then I would put most of my patients on one of these wonderful drugs.
So fortunately, we are going to get them at lesser
Yeah.
pricing soon. So with that, I'll conclude the session. Thank you, Dr. Sakib, Dr. Akash, and Dr. Shivender. It was a very interesting discussion and two brilliant presentations. I'll hand back to Dr. Vivek Vyas from Intas. And thanks to Intas, Mr. Amandeep Singh, and others for having this excellent session.
This is indeed, actual food for thought rather than late night food. That is what the discussion has handed. So it is beautiful that how from secondary prevention and disease state we have moved to the primary prevention and ultimately ended the discussion with the today's era's actual issues. So not only about the pharmacotherapy, but stress and Gen Z, everything we have talked about. So on behalf of Vector Division of Intas, I thank everyone, especially the esteemed panelists first. I'll start with Dr. Shivendra and Dr. Sakib, and of course to the speakers who are all part of it. And thank you so much to Dr. Agarwal and Dr. Gagan Priya for wonderfully moderating the entire session. So on behalf of Vector Division of Intas, once again, thank you. But before I let everyone go, our next episode is already planned in the month of April. So we will soon announce the date for the same. And we do have some numbers. We have around 1,500 plus logins across India. So once again, thank you to all the participants for the patient listening as well. Thank you so much, ma'am. Thank you. Good night. And once again, wishing all of you a very happy new year and healthy year ahead.
Good
Thank
night.
you.
Thank you. Thank
Thank
you,
you,
Intasking.
Gagan.
Thank you, ma'am. Good
Bye.
night, ma'am. Thank
Night.
you.
Night, everybody.
Thank you, ma'am.
Thank you. Thank you, everyone. Vinith, we can